We're going to do a little recap and then a summary of everything. It looks as if all the comments and everything are working, so that's good. Where have we been? Let's just pop this up here. That's the one I want. This is what we've been looking at over the last 9 weeks now. It's mad how long we've spent on this topic. It is a huge topic area, and I think by looking into it the way that we have, it shows the importance of it really, and the importance of knowing it. This is our summary of all of the 12 cranial nerves, and like I've been saying all the way through, we should know these just like we do the peripheral nerve. If you've heard of the sciatic nerve, if you've heard of the median nerve, the ulnar nerve, then really we should have done a little bit of reading around this as well. These are basically the peripheral nerves, so the light peripheral nerves for the head and the neck. We've got all of the nerve numbers down here. These are the ones we've been working through. This is where they exit the skull, but they come off of the brain. They're straight off of either the brain or the brain stem or the early part of the spinal cord, because some of them travel back up again and then exit through the skull. And they have either a sensory role, a motor role, and that can be autonomic, which is automatic, or it can be somatic. So that's something that we control. These are the names of the nerves all down here, and we're going to finish off on this one, which is hypoglossal. We're going to have a look at that one today. This is what they do, and we've gone over this a few times. There's a mnemonic to help remember what they do, so we'll show you that when we get to the slides. And you'll see whether there's an S, an M or a B, so it means sensory, motor or both. It does both. And then what does it do? And we've got down here, so you can see here, tongue and throat. That's what we're focusing on today. And then these are the tests that you can do. And what I'll do is I'll show you the testing form that we use, just so you've got an idea of, if you want to put your own together, then I'll give you a few pointers as to what to do. That is that. And this is where we finished last week. This bit at the top here, this is an excerpt from the table that you've just seen. Cranial nerve 11 is the accessory nerve, but correctly termed the spinal accessory nerve, and it exits the skull through something called the jugular foramen, and we looked at all this last week, so just a bit of a recap over those. Is it sensory, is it motor, or is it both? And this one's purely motor. This is the mnemonic along the bottom. You write out all of your cranial nerves in an exam, and then you write the mnemonic next to it, and it's, some say money matters, but my brother says big biceps matter more, and this is number 11, so this is matter. So because it begins with an M, that means that this is motor. It's a general somatic motor, so works like normal muscles in the body, but there's also a special visceral motor element to it as well, and maybe some kind of autonomic function. Let's have a look at what it does. The main thing that we're interested in from a musculoskeletal point of view is that the spinal accessory nerve is the nerve that innervates the sternocleidomastoid muscle, which is the muscle in the side of your neck. So it goes from your sternum and clavicle to the mastoid process, which is just behind the ear. And it also innervates your trapezius muscles, the upper traps in particular. What do you do to test it? You would shrug, because that activates the upper traps, and you can rotate the head. You do these against resistance to see whether there is a deficit in their strength. If there's a problem with the accessory nerve, then there may be a problem with the, well, there will be if there's a problem with the nerve, but it may not just be the nerve if there is a problem. We put it into the mix for our clinical reasoning and the kind of things that we want to test. If someone's coming in and they're struggling turning their head, there may be a number of reasons for that. Maybe due to pain somewhere that's they're guarding and not able to do it. This is literally they can't contract the muscles. Again, there's other reasons why they can't contract the muscles as well. You need to listen to the story and why they've ended up coming to your door as well. So all of that aside, this is where it comes through. The spinal accessory is part of the cervical region. It comes off of the spinal cord, but it comes back up into the skull. Basically, it's in the neck, and then it travels up into the skull via the foramen magnum. And this hole here is where your spinal cord goes through. Where your brain sits, you've got the spinal cord coming off the back. As that drops down through, it goes through that big hole there. The spinal accessory nerve has gone through there in embryology. It's been pulled through there as you grow, but the filaments of the nerve remain in the skull because there is a little gap. It's this one just here. This is the jugular foramen, and the spinal accessory nerve comes through that hole. That's how it gets up and back again. And then this is a schematic of it. Here we go. We've got spinal roots. The nucleus of cranial nerve 11 is from C1 to C5. It's actually in the neck. And then all of those roots then come up through the foramen magnum, which is here, through that hole that we've just seen. And they then travel back down through the jugular foramen, which was the second hole that we just saw. If I just go back, that is that one just there. It comes up through here and then through there. It's kind of doing a loop back on itself. And then it goes down the side of your neck here and innervates your sternocleidomastoid here and your trapezius muscle just there. The kind of thing that we do to test it is that. So if you go, how do you test the spinal accessory nerve? And you go, I don't know. Then you're halfway there. I did that joke last week, so it may not work this week. But you've got trapezius. You've got the trapezius element. If you do it with a little bit of a mono, then you get both. Okay, so you got trapezius and sternocleidomastoid that you're testing when you're doing this. And we would normally test it against resistance. Can they shrug their shoulders and can they rotate their head? It's purely motor for the SCM, sternocleidomastoid and the traps. That's a little bit of a recap. Here's the video of it. This is the spinal accessory. Just get ready with my pause button. There we go. That's the image that we've just seen. And again, we did this last week in a bit more depth, so we're going to go over this a bit quicker. In the other videos, the previous videos for the glossopharyngeal nerve number 9 and the vagus nerve number 10, as well as this one number 11, they all exit through that jugular foramen. So if you want to have a look at where they go through, then have a look at those videos. The glossopharyngeal and vagus nerve, they show the origin of where this accessory nerve comes through. Up here, you've got a hole there, which is your auditory meatus. So that's basically your ear hole. This nerve is coming out just by your mastoid process in that region there. We've got the spinal accessory nerve just coming down here. You've also got the jugular vein. And again, we talked about that briefly yesterday, because if you have a problem with the liver, there's some kind of blockage in the liver, then you get what's called a raised JVP, so a jugular venous pressure. And you can see a swelling in the neck. If you have a look up for raised JVP, then you'll see the location of that vein. That's your jugular vein. There's the nerve coming down there. You've got digastric muscle just there. And then there's the spinal accessory. We can see the trapezius just here. There's your sternocleidomastoid. That big muscle there, the sternocleidomastoid muscle, is one of the muscles that innervates. And then it also innervates the one at the back. And you can just see it just there. Where that arrow is there, you can see that line. That's basically what nerves look like. We've got this line coming down and then supplying this muscle. And when there's a signal coming down there, so a nerve impulse, then it will activate that muscle. There's the spinal accessory going into your trapezius just here. That one was nice and easy last week. Thank God. After the previous weeks, we've had some real tricky ones, especially trigeminal nerve, all the ones that come out of the supraorbital fissure, but mainly trigeminal. That was pretty heavy, that one. All of the nerves, if you remember from the beginning. They're given their name, the number, because of the position that they exit the brain or the brainstem. So number 1 literally comes off the front of the brain. In fact, you can see it on here. Those strands there, those are the olfactory nerves. They're basically heading towards your nose. That's number 1. And then as you come backwards, optic is next, and that's number 2. And then as you come backwards, that's why they're given all their names. Number 11 is really far back, right back here. And then let's just put that one. There we go. That's how to test it. You test resisted rotation and right and left, and then you resist shrugging as well. Those are all the tests for the spinal accessory nerve, which is nerve number 11. And now, hopefully, we're on, finally, after 9 sessions, we are on cranial nerve number 12. Cranial nerve number 12 is the hypoglossal nerve, and hypoglossal means under the tongue. Anything with glossal, glossus, we've seen the glossopharyngeal nerve before, that's tongue and pharynx. Yeah, again, we get an idea of what they do because of their names. If we have a look at the mnemonic is, some say money matters, but my brother says big biceps matter more, and that M for more, it means it's motor, and we've got general somatic motor, right? This is purely motor, no sensory element to this particular nerve. It does join up with another nerve, another strand, to form a loop. We'll have a look at that in a second. This is nerve number 12. The skull exit point is something called the hypoglossal canal. There is a specific exit from the skull that is very close to the jugular foramen, just underneath it, and that is where this nerve comes through. It's got its own exit point. The name is the hypoglossal, and then is it sensory, is it motor, is it both? It's motor. That's the mnemonic. What do they do? It works the tongue and the throat. What do I mean by work? It provides the nerve impulses to allow swallowing, to allow speech, the muscles in the throat, hyoid muscles. We've done a whole session on the hyoids. The test we can do is something called tongue deviation. And I'll show you a picture of that in a second. That's what it does. This is a bit of an overview of the last few weeks. This is the foramen magnum. That's what we were just looking at, where the spinal cord goes through. As it comes off of the brain, it drops down through this foramen magnum just here. This is the jugular foramen. If you've not heard of that term before, foramen just basically means a hole. The jugular foramen is where the glossopharyngeal, the vagus, and the spinal accessory nerve goes through. 9, 10 and 11 go through there. And then this one just here, which is labelled number 27 on my skeleton, there is a little hole there called the hypoglossal canal, and that is where the hypoglossal nerve comes through. It's got its own specific canal, really close to the foramen magnum. Because it's right at the back, last one, most posterior, is cranial nerve 12. That's why it's given that name. This is a schematic of that, and we'll add this into the video as we go. So if you have a look here, we've got 10 to 15 rootlets on the hypoglossal nucleus. So, and you'll see this in the video, it's quite wispy. There's quite a few offshoots off of the brainstem. It then goes through the hypoglossal canal, that hole that we've just seen in the skull. It goes past a few arteries. So we've got the internal and external carotid arteries that it goes through, but it also shoots off this descending branch. This is the superior root of something called the ansa cervicalis, and that links into another nerve to form a loop, which is quite interesting. And then this branch here, it kind of follows very close to the lingual nerve, which was part of the mandibular branch of the trigeminal. Again, that was back in the trigeminal videos if you want to have a look at that, and close to the lingual artery as well. And if we have a look where it goes, we've got a couple of branches that shoot off here, and these go to the hyoid muscles, so thyrohyoid, connecting to the hyoid bone and the thyroid, and then geniohyoid as well. And we've had a look at those when we looked at the hyoid muscles. Then we've got all of these. We've got the intrinsic muscles of the tongue. This nerve comes off here, branch off there, kind of dropping down into the throat area, and then this one here, which will go through into the tongue. We've got the hyoglossus, genioglossus, styloglossus muscles, all the muscles that allow you to move your tongue. And these are collectively the intrinsic muscles of the tongue. That's its main jobs. This one here, this will link up with another nerve from C2, C3, and you'll see it on the video in a second. And what this branch does, although it doesn't show it on here, is it will innervate all of the infrahyoid muscles. Okay, the ones that are inferior to the hyoid bone. And again, we'll have a look at that in a sec, but just to give you a heads up, that's where we're going. This is the ansa cervicalis. It's this bit just here. Okay, can you see that loop just there? So we've got C1 just coming off there, and this is the hypoglossus, a branch of the hypoglossus, going to the hypoglossus. They join in together here. This C1 branch comes down, and then there's the descending part of the hypoglossus just there, and then you can see where it's going. The superior belly of omohyoid to the sternohyoid, basically the muscles of the infrahyoids. That's where that one goes, and you can see it joins in here with C2 and C3 to form this loop. So ansa means a hook or a handle. You can see that kind of loop around there does kind of look like I think more of a handle than a hook. It innervates the muscles of swallowing and the production of your voice. So if someone's coming in and they're having problems drinking water, and they're coughing, spluttering because they can't drink the water properly, or they've got a problem with their voice box and can't speak very well, then there may be an issue with the hypoglossal nerve. Again, there are lots of other reasons why that may occur, but in the background, you should be thinking about cranial nerves too. These are the main things that the hypoglossal do. So it's motor nerve, speech and swallowing. Lesions to the nerve will cause something called dysphagia, which is difficulty swallowing, dysarthria, difficulty speaking, and the tongue may deviate to one side when it's poked out. That's part of the testing. You get someone to poke their tongue out, and if it deviates to one side or the other, then there's a problem with the muscles on one side of the tongue. Strokes, ALS, infections of the brainstem are all a possible diagnosis. This may be something that happens immediately, like in a stroke, or it could be something that's degenerative and it's getting worse over time. So again, we wouldn't have the means to test this, but we need to be aware that this could be a potential problem. And that's just another little picture just showing where the nerve goes through and where it innervates all the tongue and the hyoid muscles. And then that is something that you might see. Okay, we've got this tongue deviation, so motor, tongue and throat muscles, and that's the kind of thing that you might see with a palsy or a lesion on the hypoglossal nerve. You ask someone to stick out their tongue, and that's what you might see. So let's have a look at this. Just play this one. A hypoglossal under the tongue. Here we go. That's what we've just seen. We know that it's innervating the hyoid muscles, infrahyoids, and this is where it comes from. This is a bit of a recap of the region. What I was saying about before. This area here, that bit there, that's the jugular foramen. That's where 9, 10 and 11 go through. And then in a second, we'll see the hypoglossal, but I just wanted to show you the whole area so you could kind of differentiate between them all. Let's have a look at that. That's number 9, which is glossopharyngeal. And again, we've done a whole video on that. There's number 10, which is the vagus. And you can see that there's lots of wispy strands with the vagus as well. And then they all come together and then go through that same exit hole just up there, all through that jugular foramen. That's your vagus. Just move me out of the way again. That comes from all of those strands. And then the thicker one that you can see, that one just there, that's your spinal accessory. That's what we just had a look at on the recap. That's number 11. And then that comes from C1 to C5, which we were talking about just a second ago. And then your hypoglossal is tucked away there. That's your jugular foramen. And here we go. So your hypoglossal is all from this region here. I don't know, hopefully you can see it a little bit easier, but my screen's a little bit dark, but it's from that region. And then there's a little, you can just about make out the hypoglossal canal where it all converges and then goes through. We're looking at the rootlets, which are here. That's this area here. And then it's coming through here, the hypoglossal canal, which will be around there somewhere. On my picture, it's a little bit dark, so hopefully you can see that a bit easier. The hypoglossal all around there. There we go. Yeah, you can see it a bit easier now. And you can see them all like converging together around that point there. That's that hypoglossal canal just there. Okay. There we go. You can see the closeness with the jugular foramen. When I showed you the dry skull earlier, you could see the jugular foramen on the top and then the hypoglossal canal just underneath. Okay, jugular foramen on top, hypoglossal canal underneath, just there. Yeah, you can just about make out the hole just through there. Here we go. There's the hypoglossal canal, there's the jugular foramen. Let me just go back a bit there. Just play that again. Yeah, you can see where they all converge there on that hypoglossal canal. That's quite a good shot of it there. But we're looking basically at the back of the brain. Okay, they've obviously taken the skull off. They've taken the cerebellum off, which is the kind of chunky bit at the back of the brain, so that you can see the brainstem and the cord. There we go. There's your hypoglossal canal. That's similar to the image that we just saw. Foramen magnum just here. Foramen means hole, so that's a big hole. Foramen magnum, and then jugular foramen just here. Okay, so you can see it's got its own exit point, which then corresponds with the schematic just there. Just press play again, there we go. And that's a hypoglossal canal. And then it will flip around. Just move me over there so I'm not in the way. And if I just pause that there. So there's your mastoid process. That's the bit behind the ear. There's your ear roll. Okay, obviously we've got an earlobe, but if the earlobe wasn't there, there'd just be a hole. So you can see the kind of region that we're in. We're kind of just in front of the ear roll. There we go. And then there's your hypoglossal canal. Just go back a sec. Didn't pause it quick enough. Just go around again. Here we go. Pause that there, cool. Yeah, there's your hypoglossal canal, that bit just there, and then there's the jugular foramen. Over the last couple of weeks we've been focusing on this area, and this is the one we're interested in today. They all come up out of a very, very close place. There you go. That's what it is on the main picture, okay, as it's coming through there. So when it comes through, it then immediately splits, and it splits just before the carotid arteries. Let's have a look at that. Okay, so here we are, just pause that there. Yeah, again, a little bit of a recap. The glossopharyngeal nerve just here. There's your jugular vein, similar to the image that we were just looking at. There's your external auditory meatus, so that's your ear roll. Obviously your lobe would be on that normally, and then we'll go through some of these nerves. There's your vagus. We've had a look at that before. That tracks down in between your carotid artery and your jugular vein, and then remember it went all the way down and back on itself. So the recurrent laryngeal went and innervated areas of the gut, around the heart. The vagus, well, vagus means like vagrant, so wandering. Off it wanders. And yeah, go, and one of the longest nerves in the body. Accessory nerve just there. That was the one we'd just seen. That goes off to your sternocleidomastoid and your trapezius. And then there's your hypoglossal. It's quite a thick nerve, that one. Yeah, look at the relative thickness with all the rest of them. But obviously quite an important job with swallowing and speaking. It's very important that we are able to do those things. Yeah, this is the other side of the canal. The canal's up here. This part of the nerve here is basically this bit. And you'll see it in a second where it starts to split. I'll just try and pause that at the right moment. There's your hypoglossal. Yeah, And then there's your internal carotid just behind it. I don't know whether you can make that out. Jugular vein just there, internal carotid just there, hypoglossal there. There's your internal carotid on the image. You can see as we track through, and I'll try and follow it on the schematic as well. Like I've said before, actually, that the schematic drawings don't show you exactly the pathway. It's like the tube map, so the trains don't go in straight lines, they go all over the place, but they make it look like they're in straight lines, so it's easier to see. Here's the split in two. So there we've got a descending branch, and then this is the one that is off towards the tongue. There's the one off towards the tongue, and then there's the one down towards the throat. That's where it splits, and it's this one that loops back and then joins in with C2 and C3 to form that hook, that ansa cervicalis. There, yep, there's your external carotid. We're up at around this area here, okay? That's that branch of the hypoglossal, so just after the split, okay? Another muscle there, styloglossus. It goes from the styloid to your tongue. And then that's where the stylohyoid would be, and the posterior digastric. And again, we've looked at all of those when we did the hyoid muscles around the neck. We've taken all those away. So here's the descending branch. We've got some of them are innervated by some areas of it innervate the thyrohyoid and the geniohyoid. I think there's some little offshoots. Let's have a look. There we go. Yeah, there's your hypoglossus muscle, which is that one just there. That's it just there. And can you see where this part of the nerve then dives in between these two muscles? We've got that one there, the hypoglossus, and then I think it's the mylohyoid as well. Let's have a look. There's just in front there. Yeah, myohyoid just in front. And the nerve goes through those two muscles to get to your tongue. Okay, there's the lingual nerve as well, which is the branch of the trigeminal that we were talking about before. It links everything up together. We're talking around the jaw area now. That's roughly where we are. And then it supplies all of the intrinsic muscles of the tongue. When it enters that space, so it's able to get, because obviously your jaw's not there on this, but underneath there is just all soft tissue. It's then able to travel through those muscles and get to the tongue. Okay, so all the muscles, or pretty much all the muscles of the tongue, are supplied by the hypoglossus. That's why if there's a problem with it, then you get that tongue deviation. And this is the descending branch, this bit here, and then that's the bit that creates this loop. And you can just about make out the loop just there. And let's have a look at that. There's the jugular vein, descending branch just there, and then there's a couple of little branches that come off here and here, and then it loops back on itself and then attaches up into another part of the, there we go, this bit here, C2 and C3. That bit there is that bit there, and then we've got that branch there wrapping around, that is that bit there. Part of the cranial nerve links up with another nerve that is coming off of the top section of your spinal cord, C1 and C2. Okay, it loops with C2, C3 to form the ansa cervicalis. We've got a branch from C1, which then becomes hypoglossus, and then C2, C3 then form this loop all the way around, and then these supply the hyoid muscles, your throat muscles. There it is wrapping around. Ansa cervicalis just there. And then we've got, there we go. So it innervates all four infrahyoid. Infrahyoid means inferior to the hyoid bone. We've got thyrohyoid, omohyoid, sternothyroid, and sternohyoid. All of those muscles of the throat, which help you swallow, those are controlled by hypoglossal and the ansa cervicalis from C2, C3. And again, any issues with that and you will struggle with swallowing. Cool. And I think that's it. Yeah, perfect. That's what happens when it goes wrong. You get that tongue deviation. Let's have a little bit of a summary then. That was the hypoglossal. I'm going to try and bring everything all together. Hopefully that all makes sense. The name of it makes sense. Hypoglossal means it's got to do with the tongue and then below, under the tongue. And then you can kind of work out what it does as well from that. But your summary table, I can't really move me anywhere apart because I'm going to get in the way everywhere. Here we go. Let's take me off completely. We've got all the names of the nerves down the side there, all of the exit points, all of the names of the nerves, plus the mnemonic that you can remember him by. To touch and feel very green vegetables. Aha. Then this one here, some say money matters, but my brother says big biceps matter more, and that is whether they're sensory, motor or both. You can write those both out if you're doing an exam. What do they do? Smell, sight, eye muscles. Obviously all the ones that are towards the front are to do with the top part of the head, and then as they move down and down and down, then we get to the tongue and the throat. It basically starts at the top of the face and then works all the way down. And then these are the tests that you can do to test all of those nerves. That's that in a nutshell. These are the skull exit points in a nutshell. Hopefully now this image starts to make a bit more sense after doing this for 9 weeks. Okay, we've got the cribriform plate at the front. That was for the olfactory nerve, the optic canal where the nerve for the back of the eyeball. You got the superior orbital fissure, and there were a few nerves that went through there, and they help to control the movement of the eye. What else have we got? Yeah, part of the trigeminal nerve, the ophthalmic, went through there as well. Then we've got foramen rotundum, which was the maxillary branch of the trigeminal nerve. Foramen ovale, which is the mandibular branch, so around the jaw. We've just seen a bit of that with the lingual nerve. Internal acoustic meatus, this bit here. Obviously we've got an outside ear hole, we've got an inside one as well, and the nerves go into the inside one and then travel towards the outside one, and that's your facial and vestibular cochlear nerve, which we covered a couple of weeks ago. Jugular foramen, which we've seen today, that was nerves 9, 10 and 11 going through there, and then that tiny little one today, the hypoglossal, which is cranial nerve 12. All of these little holes in the skull that you should now be familiar with, and you can test yourself on those now if you really want to. What do we do to test it then? Well, as you can see, there is a lot to remember. My memory is terrible, and whilst I remember most things, I still need some kind of aid memoir, and also so that I don't make mistakes. I don't want to miss something and then think, oh, damn it, I should have tested that. So I've created forms which were originally for myself because it's something that I felt I needed. And then since teaching courses, then we make them available to our students. These are the kind of things that I would look for. This is a very, very quick 1 minute test of the cranial nerves all the way through, pretty much all of them, the nerves name and then what they do, and then you can write any notes. So if someone is coming in with dizziness, any kind of headaches, neck pain, that kind of thing, you could just casually go through and talk about these kind of things as you're going through your assessment, just like you would if someone has lower back pain and they have lower back pain and then they have had some tummy troubles and trouble going to the toilet, and they don't associate trouble going to the toilet with back pain, but we do, or we should do. And if we don't ask the question, then the patient won't tell us. They'll just be focused on their back because they think it's a musculoskeletal problem. We need to do the same with the head and the face and the neck. If you have had neck pain, have you had any bouts of dizziness? Have you had any double vision? Have you had any difficulty swallowing? As you're obviously talking to them, you can hear them talk and you know whether they've got a problem with their speech. We start to bring in some of these, once you've been doing it for a while, into your normal screening process for a head and neck problem. But at the beginning, really, it's useful to have a form. This should literally take a minute to do, and that literally is a 1 minute check. We've then got a more detailed check, which goes through all of the nerves in order and in a lot more detail. And what I've done as well, just so you kind of remember, because I'm a bit more of a visual person, you've got these images as well to show you what to look out for. So you can produce those yourself and create your own forms. So let me just show you some of these, and let's hopefully I'll be able to zoom in a bit. Hopefully, just grab hold of that end. So I'll just show you what they're like. Yeah, there we go. That's better. Yeah. 3, 4, and 6, observation of the eyes. Is there any ptosis, any drooping eyelids, or any nystagmus? Is the eye flickering? There's just a little bit of a cue, really, just to make sure that there's nothing untoward. Something with the optic nerve is a direct reaction, consensual, and accommodation. You can check, get them to close their eyes and cover an eye just to see what happens to their pupils. Facial expressions, is there any droop and weakness? So get them to raise their eyebrows, bare their teeth, or a whistle, puff their cheeks. You can really quickly test all of these. If there's a problem with the trigeminal, it obviously does more things, but this is the quick test. Does the jaw deviate to the side? Does the jaw deviate as they open their mouth, and it will deviate to one side or the other? Again, that can be a number of different things, but we would do that test just to see if it corresponds to any other symptoms. And then if I just show you an example of one of the other ones, let's get rid of that, bring that one in. Yeah, this one's a little bit more detailed. It depends on the level of detail you want to go to, really. And then this one here, yeah, for today, the cranial nerve number 12, the hypoglossal, tongue movement deviates to the side of the lesion. You get them to poke out their tongue. And again, it's one of those things where I've only come in for a massage on my neck because my neck really hurts, and then you get me to poke out my tongue. What are you talking about? Obviously, it needs to be explained first of all why you're doing it, the reasons for it, but it's exactly the same as talking about cauda equina problems. Okay, if you explain it properly and the reasons why, and it won't take you long, then they should be fine with that. The full assessment will usually take around about 10 minutes. Because you need to alter the lights and get a proper Snellen chart and all that kind of stuff. But yeah, if you just want to do something quickly, it will take a minute to do. That is the cranial nerves. All done. From cranial nerve 1 all the way through to cranial nerve 12, how to test them along the way, what they do, how to remember them if you're doing an exam, and hopefully you never have any patients with any of those problems.